Hi, my name is Yasmin A Lyons, and I'm a third-year Gynaecologic Oncology Fellow at the University of Iowa, working with Dr. Jesus Gonzalez-Bosquet. Thank you for the opportunity to present the findings from our recently published manuscript in the International Journal of Gynecologic Cancer titled Interval Debulking Surgery is Not Worth the Wait, a National Cancer Database Study comparing primary cytoreductive surgery versus neoadjuvant chemotherapy. Recent randomized control trials, including Scorpion and the JCOG study, were performed as updated trials to address criticisms with EORTC and CHORUS. Neither study showed a survival difference nor superiority of one treatment over the other. The goal of our study was to use the National Cancer Database to evaluate outcomes such as mortality, morbidity, and survival to see if these factors could help in choosing the best primary treatment. We extracted data from the National Cancer Database between 2004 and 2015. Survival was estimated using Kaplan-Meier, and we compared survival between groups using Cox proportional hazard ratio. Univariate analysis was used for covariates including age, stage, Charlson Comorbidity Index, and grade. We validated our data by excluding high-risk groups of patients at risk of not responding to treatment and by performing propensity score matching. After applying our exclusion criteria, we were left with 36,602 patients for analysis. Those patients in the neoadjuvant chemotherapy group were overall older, with more comorbidities, more advanced stage cancer, and higher grade cancer. They also had a higher rate of no gross residual disease at the end of surgery. Mortality at 30 and 90 days was higher in the neoadjuvant chemotherapy group, but after excluding high-risk patients, there was no difference seen at 90 days. Those patients that underwent primary cytoreductive surgery with no gross residual disease had the best survival at 62.6 months. Those patients that underwent neoadjuvant chemotherapy and had gross residual disease had the poorest survival at 29.5 months. Patients that underwent primary cytoreductive surgery with gross residual disease and those that underwent neoadjuvant chemotherapy without gross residual disease had survival curves that overlapped. In conclusion, we recommend primary cytoreductive surgery for most patients with advanced epithelial ovarian cancer in order to maximize survival benefit. We recommend reserving neoadjuvant chemotherapy for those patients that are medically unfit for surgery and those with unresectable bone, brain, and liver metastasis.